Can you hear me? Can you hear me right now?
Yes, I can.
Okay. Thank you. And you may also have my picture, yes? Okay. Hello, everybody. I'm Dr. Ehsan Aghaei. I'm pediatric cardiologist, and I'm an assistant professor in Tehran University of Medical Sciences. On behalf of me and my colleagues, I would like to welcome all of our friends and guests and audiences to our first presentation and webinar on COVID-19 from the pediatric department of Tehran University of Medical Sciences, located in Chelsea Center, the Pediatric Center of Excellence. I also want to thank dear Dr. Ziai and also the Office of Vice Chancellor for Global Strategies and International Affairs of Tehran University of Medical Sciences. I should remind that this is not the official point of view of Tehran University of Medical Sciences, and it is personal point of views of the panelists that will be discussed in our session. First, let me just introduce to you the TUMS, Tehran University of Medical Sciences. As many of you may know, this is the oldest medical school in Iran, and also one of the well-known universities in whole region. The purpose of this webinar is to share experience with you about COVID-19 in pediatric patients, and we will have these webinars in the manner of every other week at the same time, almost at the same time. The length of the session will be about 1 hour, and we will present to you 1 or 2 cases depending on the time. You are more than welcome to share your valuable point of views with us and also ask questions in the chat section of the program. But sadly, we do not have enough time to have each one of the audiences to speak for themselves. So just write them down in the chat section, and me and my colleague will share them with the panelists right here, and also with our experts. So feel free to ask the questions and share your valuable point of views. So let us go to the first case and start with the introducing the panelists of the first panel. Our panelists for the first case will be dear Dr. Mehrzad Mehdizadeh, radiologist and associate professor in TUMS. My friend, dear Dr. Sayadpour, pediatric cardiologist and also associate professor in TUMS. Dear Dr. Masoud Mohammadpour, pediatric intensivist and one of the most well-known pediatric intensivists in whole country, and also associate professor in TUMS. Dear Dr. Mohammad-Hosein Alami, pediatric infectious specialist from Mehrzad University of Medical Sciences. In this panel, the case will be presented to you by dear Dr. Maryam Bakhtiari, one of our distinguished residents in Children Medical Center, the Pediatric Center of Excellence. So I just want to ask her to start presenting our first case. Okay. Sorry, dear Dr. Maryam Nasri will present the first case to you. So if you may start. just wait for the. We do not have your sound. Just wait a minute. I think you should open your microphone. Yes.
Hi everybody, I'm so glad to have your participation in this session. I'm Dr. Nasri, first year resident at Tehran University of Medical Sciences. Um, our case report is about story of hypoplastic left heart syndrome since he has been born. He was admitted at Children's Medical Hospital 45 days ago with chief complaint of low-grade fever, restlessness, and cyanosis that has been started gradually within 3 to 4 days before admission. During our investigations, we couldn't identify any of his relatives with the same symptom. He was born by NVD at a gestational age of 38 weeks, and he was second child of the family. He had hypothyroidism, hypoplastic left heart syndrome that has been treated partially via balloon aortic valvuloplasty and percutaneous transarterial aortic commissurotomy and ductus arteriosus stenting when he was 20 days old at CMC. Also, he was infected with the influenza virus 5 months ago in autumn and again was admitted at Children's Medical Center at that time. Unfortunately, after discharge, he developed Eisenmenger. His medications was sildenafil, captopril, ISA, and lanoxine. When he was admitted at the center, he was obviously cyanotic but conscious. And in the vital signs, the respiratory rate was 50 per minute and the O2 saturation was 66%, but after oxygenation increases to 81%. Also, he had a low-grade fever and heart rate about 130 per minute. In the limbs, he had clubbing in nails, but no signs of edema, a mild ascites, and edema in the scrotum. In cardiac examination, we osculated a systolic murmur, and also he was tachypneic, but no pathologic respiratory sound osculated. In abdominal examination, mild ascites with no signs of organomegaly was noted. Now I want to mention the echocardiography that has been done for him. It was noted that he had SDS, HLHS, PDA stent, also severe LAH, and mild AS, mild AI. And after that influenza virus infection, he developed Eisenmenger syndrome and ejection fraction about 55 to 60%. Here, I want to share the most important lab data. I will tell you at the admission and last day. As you see, both of them, we can see leukocytosis, and also at the admission, the CRP was 51, but it increases to 230. Also, at the admission, he had leukocytosis, but in the last day, we saw neutrophilia. And you can see other lab data here, albumin, sodium, potassium, creatinine, BUN, and ESR. And here the VBG and also the PT, PTT, INR was disrupted because of the past drug history of lanoxine. And you can see the liver test and LDH, CPK, uric acid. And the most important is that nasopharynx PCR of COVID-19 was positive. Here, I want to share the chest CT scan. As you see here, there were multiple opacities in both lungs. in favor of COVID-19 infection. And also chest X-ray, that we can see multiple opacities here too. The ECG, that's in favor of right ventricular hypertrophy due to his past medical history. And not the most important thing is that what has been done for him. Because of his situation, we done ICU admission and isolated him, nasal oxygenation, daily ECG, and also for scrotum edema, we did scrotum elevation, clindamycin, ceftazidime, Lasix, and also azithromycin and hydroxychloroquine that are experimental therapy for COVID-19 in this center, and also ISR captopril, levothyroxine, vitamin E, and Libergo. Finally, in last days, we found evidences suggestive of pulmonary hypertension and decrease in ejection fraction. Due to bradycardia and right ventricular failure, the patient's heart stopped beating. And unfortunately, despite all our attempts to resuscitate, the patient died. And now, if I want to summarize, a 10-month boy with past medical history of HLHS was admitted with low-grade fever, cyanosis, and due to COVID-19 pandemic, we were suspected of this infection. Chest CT and X-ray were in favor of COVID-19 infection, and it was proved by PCR. Here we have pediatric specialists near us, and we want their point of view to hear their point of view. I have some questions, and I want to know what are cardiac effects and complications of COVID-19.
Okay, thank you very much, Dr. Nasri, for your good presentation of the patient. So we are, in summary, we are facing a very critically ill child with an underlying disease that ended to Eisenmenger, and now he was facing COVID-19, and regardless to the underlying problem, we are discussing a patient of COVID-19 and Eisenmenger. So first, I would like to ask Dr. Mohammadpour about the patient, and I will look at the questions that have been asked most commonly about the patients in ICU setting. Dear Dr. Mohammadpour, can you help us with the special considerations for the COVID-19 patients which needs intubation and also mechanical ventilation and are admitted in the ICU settings? And is there any special considerations that should be checked for the patients and the protection for the personnel that are necessary? Can you discuss them with us?
Okay, thank you, Ehsan. Good afternoon, everybody. Here I give you a brief report of airway management in suspected or confirmed patient with COVID-19 infection. First of all, we have to protect ourselves and make the environment safe for our personnel. This is done through use of proper personal protective equipment. It is called donning. Donning has a special sequence of works which we have to do. First of all, this is hand hygiene for 15 or 20 seconds. Then gowning. Next step is proper mask. It must be N95 or FFP3 for all patients who have contact with droplets of the patients. And then shielding over the eyes and head, and finally use of gloves. You know, whenever we are in doubt of intubation, it is better to intubate everywhere, every time. Intubation is a clinical diagnosis, not a laboratory diagnosis. Clinical judgment, autosaturation, dyspnea, respiratory rate, and other factors such as chest X-ray may help us. Tachypnea isolation is not an indication of intubate. Other findings may help us better, such as palpation of the sternocleidomastoid muscle, and the phasic contraction of this muscle, especially in older children, is the most important sign. Professor Martin Tobin is a worldwide known leader in mechanical ventilation. He says the surest way to increase COVID-19 mortality is liberal use of intubation and mechanical ventilation. So we have to think again before intubation in non-cardiopulmonary resuscitation events. Rapid progression over hours, evolving hypercapnia, and hemodynamic instability are all signs that inherit intubation. There is a new article in JAMA in the field of clinical updates, and the name is Management of COVID-19 Respiratory Distress. In this article, there is a new term. It is CARDS. We have ARDS, Acute Respiratory Distress Syndrome. Now we have COVID, Acute Respiratory Distress Syndrome, and it is CARDS. And soon after onset of respiratory distress from COVID, patients initially retain relatively good compliance despite poor oxygenation. Minute ventilation is characteristically high. Infiltrates are often limited in extent and initially are characterized by ground glass pattern on CT scans, which signifies interstitial rather than alveolar edema. Many patients do not appear overtly dyspneic. These patients are characterized by low lung elastance or otherwise high compliance and low response to PEEP, may stabilize at this stage without deterioration, while others go to the advanced stage of ARDS. And now it's time to intubate the patient. And when we have to intubate a patient, we must limit the number of personnel in the intubation room. We have to use rapid sequence intubation. Rapid sequence intubation has a sequence that is it has two parts. The first part is in common in all patients. It is peroxygenation, pre-treatment with atropine or fentanyl or lidocaine, sedation with etamidate or ketamine, proper positioning, and post-intubation management. But what is different in COVID patients is that we have to do intubation in a negative pressure room with at least 12 cycles of air exchange per hour, if it's at all possible. It is better to do intubation with video laryngoscopy. If any need for bag and mask ventilation, it is mandatory that 2% 200 mask ventilation be done to achieve proper sealing and prevent droplet spreading. After intubation, what is important in these patients are tracheal tube clamp. There must be a smooth clamp on the tracheal tube, and if the patient is not active, doesn't have active inspiration, use of HEPA filter or closed suction is highly recommended. Now we talk about mechanical ventilation in these patients. There are two ways of mechanical ventilation, invasive and non-invasive. Lots of doubts and conflicts are in the non-invasive ventilation in COVID-19 infected patients, but some authorities advise it. If we use it, it must be done in a proper room with proper air exchange. It must be done with conventional two-line circuit ICU ventilators and not with a single-line portable ventilator. We must use full face mask or helmet to have good seals. And the strategy of mechanical ventilation is worldwide in ARDS. It's low tidal volume, plateau pressure, less than 30 centimeters of water, and PEEP about 5 to 6 centimeters of water, and with formal PEEP adjustment based on FiO2. It means higher FiO2 needs, higher PEEP required. And and again, what is important is that extubate the patient as soon as possible. And in extubation, we have to consider not using T-tube and use PS CPAP. That's all. Thank you very much.
Thank you very much, dear Dr. Mohammadpour. As I understood, the first and the most important thing about a patient in an ICU setting is to protect yourself and also your personnel, and then think about the best strategy to treat the patient. Thank you for sharing that experience and that knowledge with us. And Dr. Sayadpour, can I ask you, are you aware of any special congenital heart disease that can make a patient more susceptible to the infection of COVID-19? Have you any experience with that? And also, are you aware of any special cardiac manifestations for COVID-19? Can you just answer me? And thank you very much for sharing your experience with us.
Hi, everybody. Yes, I am collecting case series of pediatric patients with congenital heart disease and COVID, symptomatic COVID. And based on this experience, there are two cases of mine. One is this case, and there is another one, and the other case are from my other colleagues. And it seems that patients with severe aortic stenosis, it means that the stenosis in the aortic valve, and the patients with severe pulmonary valve stenosis or other stenosis at the right ventricular outflow tract. And third, the patients with severe pulmonary hypertension, especially those with pulmonary vascular obstructive disease. Like this case, there are the three group of congenital heart disease patients at risk of symptomatic COVID. As you know, many infant children infected with this virus, but the symptomatic cases are not too much. But in this congenital heart disease, the infection can be symptomatic, severe, and even like this case, may be fatal. So it's important if a case, any congenital case, congenital heart disease case, have these problems, severe stenosis in the LV, left ventricle, severe stenosis in right ventricle, outflow tract, or pulmonary hypertension. We should do our best to treat these patients. Otherwise, if they develop infection, the infection may be serious or even fatal, like this case.
Okay, and is there any limitation for the cardiac? Do you have my voice?
Yes, yes.
Yes. Is there any special limitations for the drug medications in the patients with COVID-19? Are you aware of any drug that should not be given of any cardiac medications? Are you aware of that?
Yes, there are some discussion. One thing is about the angiotensin ACE inhibitors and angiotensin receptor blockers, which there are some discussion. Maybe they are a beneficial effect and they prevent coronavirus infection, or they may be deleterious, they may be harmful. So it's not known at this moment, but many of our patients receive these drugs. The recommendation is to continue receiving these drugs, and if an infection develops, so to stop this medication. The other one, which is important, are diuretics, because they may develop hypokalemia, and it increases the risk of QT prolongation. We use, for example, in this patient, we use azithromycin and hydroxychloroquine, which both can be harmful with a diuretic. These drugs are most important to consider in patients with COVID-19, cardiac drugs. Other drugs, not too much important, but to be aware of the risk of coagulopathy in this patient. Maybe there are some need to change. For example, this patient had the thrombocytopenia, so and receiving aspirin, so maybe it's important to change the anticoagulants during the infection based on the coagulation profile of the patient. Yes.
Okay, thank you very much, Dr. Sayadpour, for sharing your valuable knowledge and experience with us. Next, I would like to ask dear Dr. Mehdizadeh, what can we expect in the chest X-ray or CT scan of a pediatric patient with COVID-19? Is there any special difference between the chest X-ray and CT scan of these kind of patients and their adult counterparts? Is there any difference between the pediatric group and also the adult group with COVID-19?
Hello, everybody, and thank you very much for inviting me to this webinar.
You are most welcome.
As you know, pulmonary presentation in COVID is not exclusive, and other conditions such as viral infection, atypical pneumonia, aspiration, pulmonary edema, and volume overload, and other area space consolidations can be same as in COVID-19. So in a neonate, we cannot confirm exactly these findings, such as area space consolidations and alveolar involvement are most finding in COVID-19, but it's important when you are positive clinical and lab data for COVID-19. So, as you know, in a neonate with pulmonary hypertension, with pulmonary edema and aspiration, you have same findings in the chest X-ray and in chest CT, same as COVID-19. And I think that it's very important to confirm lab data and clinical data with CT and chest X-ray.
Okay, so you are telling us that there is no pathognomic finding in the CT scan or chest X-ray of these patients, and the mainstay of the diagnosis should be the physical examinations and the chief complaint of the patients, and then we should go to the lab data like CT and chest X-ray. Yes.
Exactly. For example, in patients with aspiration pneumonia, you have alveolar consolidation, patchy alveolar consolidation, and you cannot recognize exactly COVID-19 in this patient. But when you have positive PCR or a history of mother involvement with COVID-19, you can guess that this patient may have COVID-19 too. But there is no any significant finding for COVID-19 in chest X-ray and CT. But in recent reports, all of the reporters say that alveolar consolidation, especially in peripheral, is the most important thing in COVID-19. And patchy consolidation, patchy alveolar consolidation also is very important, but no evidence of pulmonary effusion, pleural effusion, or pericardial effusion. These findings are not significant for COVID.
Oh, very nice, very nice. And also, is there any difference between the findings of COVID-19 in the adult patients and the pediatric patients? Is there any difference, or they are like the same?
The COVID presentation in pediatric group is very limited, and we cannot confirm all the reports all over the world because our experience is very limited. But in recent reports, I found that all of the findings in chest X-ray and chest CT is same with adult group.
Thank you very much. Thank you very much for your very nice and also concise speech. So finally, I would like to ask dear Dr. Alami, first I would like to welcome you to our seminar from Mashhad, the holy city of Mashhad, and I would like to ask you what can be about these kind of patients what is the best approach for the protection against COVID-19? In general population, the people might think that the infants, especially infants and also children, are safe from. Agree with them, or are there any special strategies that we should take for the safety of our children?
سلام عرض میکنم. I should thank my colleagues and my friends in Tehran University of Medical Science to invite me to this interesting webinar. Good question. Your children are safer than your wife. Your wife is in danger, not your children. Because this is in COVID-19 in children is often mild. In immunocompetent children. There was a paper in CBC News told that healthcare workers are choosing to live apart from their families due to COVID-19 infection. This is the strong story. This is a story of a family. Father is a doctor in ICU, and his wife and also his two sons decided to move out from their home for indefinite period of time. The rise of COVID-19 in case creates anxiety in healthcare workers, and some of them rent an apartment to live apart from their families. What should we do? There are some ways to prevent COVID-19 infection in our families. First, take the right precaution at work. Appropriate precautions at work can minimize risk of infection and prevent families. One way is to screen patients before admission for sign of fever or respiratory symptoms. If possible, test patients before admission. There are simple tests like PCR. Before admission patient, you can test the patient for PCR, for cardiac catheterization or other procedures. We should provide a safe work environment, such as good ventilation in our work, environmental safe cleaning, and safe behavior during work, and etc. Use adequate PPE, personal protective equipment, before any operation. Hand hygiene is the best way to protect ourselves and our family against coronavirus. I believe that contact with contaminated surfaces is the most common route of transmission of coronavirus. And proper hand hygiene with alcohol-based hand rub for 15 seconds, or soap and water for 40 seconds is the best way to prevent coronavirus infections. Social distancing is very important and is a good option. But when you have to go to a crowded place, or you have not any control on person around you, it's better to put mask. Most important is surgical mask, but you can use closed masks. I should remind you about appropriate use of gloves. When you use gloves in the community or in general ward, you can touch every surfaces, every tools, and your hands with gloves are contaminated, and you are the source of spreading coronavirus infection in the hospital or in the community. It's better to have pocket hand rub in your pocket, and you carry pocket hand rub. Every time you touch surfaces, you hand rub. It's better to hand rub. You wash your hands clean, and you are safe for other people. You are not selfish. Only you are important, and you use gloves for you. It's better to use alcohol hand rub in your pocket. My president hospital, my president hospital, Dr. Jafari, provide pocket hand rub for every healthcare workers in the hospital, in pediatric hospital. And every person in the hospital carry pocket hand rub and use it if necessary. Thank you so much.
Thank you very much for your very kind and also useful consultations. And fortunately, in our hospital, we are all sharing same experiences about washing our hands and using some alcoholic or non-alcoholic hand washes. But just one question is left for me, and it's about our clothes. Should we change our clothes every day when we are going back to home? And how much is the half-life of a virus on our clothes? Do you know anything about that? I'm missing your voice. Your voice. Oh yes. Now you can talk.
Yes, the virus can remain on your clothes for less than 24 hours. You can change your clothes when you're entering the room, but you know, the root of infection is your face. When you touch your face, your nose, and your eyes, you can get the virus, But when you change your clothes and washing your hands, it's safe. Some hospitals has discipline, special discipline. When I was in Hong Kong about 5 to 6 years ago, the entrance of the hospital, when you enter the hospital, you change your clothes, you have a shower, and after coming back, you change again your clothes and come out of the hospital. This is a good discipline for a hospital that care for coronavirus disease.
Okay, thank you very much, sir. Dear audiences, you can share your experience and also your points of views in the chat. We will share them with our panelists. So let us go to the second patient, and I have the honor to present our next panelists. First, we have Dr. Keivan Mirnia. He's neonatologist and assistant professor in TUMS. We also have dear Dr. Mahsa Naemi, perinatologist from TUMS, working in Shariati Hospital. Dear Dr. Mohammad-Reza Abdulsalehi, infectious disease specialist here in TUMS. And also, again, we have dear Dr. Mehdizadeh with us with the radiology findings of the second patient. The second patient will be presented to you by dear Dr. Maryam Bakhtiari, one of our most talented pediatric residents in CMC, the Pediatric Center of Excellence. And I would like to ask dear Dr. Bakhtiari to present the case to you, please.
Do you have my voice?
Yes.
Okay, so
Loud.
everyone, I'm Bakhtiari. I'm a second-year pediatric resident in Children's Tehran University of Sciences, and I will be presenting the second case to you guys. So let me just share my slides. Okay, so the patient that I'm going to present to you today is a 32 days old term infant with fever and poor feeding from 2 days prior to admission. There was no history of cough, coryza, or respiratory distress. The baby was the first child of the family with gestational age of 39 weeks, the result of an elective C-section without any birth insult. There was a history of cough in mother prior to giving birth with negative COVID-19 PCR but with suspicious chest atrocity involvement. The mother was admitted to infection giving birth for 5 treatment for probable COVID-19 infection. The baby was separated from mother immediately after birth and was observed in a neonatal ward for any signs of COVID-19 infection, and she was released from hospital after 2 days in good health. She for 2 weeks after contact with her mother during this time. Also, there was no other contact with any other suspicious people. So on physical examination, the infant was awake and restless. There was no respiratory distress. The temperature was 38.7 with the pulse rate of 142, blood pressure of 80/50, and respiratory rate of 55. The O2 saturation on admission was 94% in room air. There was some fine crackles in both lung auscultations, but there was no other abnormal finding in physical examination. And see here, these are the patient while in admission. See here, the blood sugar level was 70, BUN of 9, creatinine of 0.6, LDH of 379, CPK of 48, sodium of 136, potassium of 4.8, and these are all in normal ranges. The CRP level was 25, which was a bit, and the ESR was 4. The procalcitonin level was checked, which was 4, which is in normal range in our laboratory. There was also a complete blood count done, which was the white blood cells were 10,200, with the absolute neutrophilic count of 7,200 and the absolute lymphocytic count of 1,860, which is a bit low. The hemoglobin level was 14.9 and the platelet levels were 263,000. The coagulation studies were normal. Also during admission, a lumbar puncture was done, and this is as I'm telling you. The glucose level was 47, protein of 52. There was no white blood cells or red blood cells, and the smear was negative. Also, the CSF culture was also negative. A urine analysis and a urine culture was done also. They were both normal and negative, and the blood culture was also negative. During admission with a suspicious of COVID-19, especially with the consideration of the mother's history of the cough and the admission, we did a COVID-19 PCR of nasopharynx secretions, which was reported positive. So these are the main things that we did for the patient. The patient was admitted. There were some IV therapy and hydration done. The antibiotics that we gave the patients were ampicillin and cefotaxime. Also azithromycin was added. There was a lumbar puncture done, which I told you the results, but in short, they were normal. And chest HRCT was done that we will see in next slides. And also a COVID-19 PCR, which I told you that it was positive. As you can see here, this is the chest x-ray that our professor, Dr. Mehdizadeh, will talk about them in shortly and will guide us through that. And here is the chest HRCT. Okay, so panelists next about their opinions. The outcome of the patient was that she was released from hospital after 5 days with improved health and no fever, and with also a negative COVID-19 PCR. So in summary, the patient was a 32 days old term infant with no prior history, born to a mother suspected of COVID-19, with chief complaint of fever and poor feeding from 2 days prior to admission. There was no respiratory distress or tachypnea with normal O2 saturations. In lab results, the significant lab results were the lymphopenia that we saw, also a high CRP level, and a positive COVID-19 PCR. The antibiotics were ampicillin, cefotaxime, and azithromycin, and also the patient was discharged in good health with improved condition after 5 days. So we had a few questions from our panelists that we would like them to discuss them if they may. So the first question we had was, are there any signs of vertical transmission? Did we have any proof or any studies done on that? Is there any sign of vertical transmission, the transmission of COVID-19 from mother to baby during birth? What are the suggested treatments in neonates? What are the radiologic findings in neonates? And also, what is the preferred delivery method in suspected mothers? Is there a vaginal delivery or C-section? Which one's preferred? How's the situation with lactation? Is there any contraindication with lactation with these mothers and with these in these situations? And last but not the least, what are the preventive measures with mothers infected with COVID-19? Thank you for your attention. I'm all yours.
Thank you very much for your very nice and also fluent presentation of this patient. First, I would like to ask Professor Mehdizadeh, is there any special findings in this patient? Have you seen the chest X-ray and the CT scan of this patient? And in my opinion, I couldn't find any special presentation of this patient. And as you have said, it is very important to just see what is the physical examination and the chief complaint of the patient, and then go for the chest X-ray and CT scan. Is there anything special for the? Is there anything special for the neonates with the COVID-19? Can you share your experience with us?
And thank you again. Can I see again the chest X-ray and CT scan, because you passed so fast from them?
Yes.
But as I said before, all of the findings in patients, especially in neonates, are non-specific. If we were not in COVID pandemic, exactly I report this chest X-ray normal for neonates. The consolidation in right side and the paracardiac portion of the chest X-ray is exactly normal, and these are pulmonary vascular, pulmonary artery and pulmonary vein. And if you clean it from the chest X-ray, where is your pulmonary artery and where is your vasculature? It's normal. And notice the thymus. Notice the thymic sign, and the thymus is exactly normal. When a neonate or a children has stress and fever and septicemia or pneumonia or involvement with COVID-19, the first sign is regression of thymus of the in chest X-ray, and you notice that the mediastinum is normally wide, and it's the shadow of thymus, and it resembles that the patient is normal. And notice the CT scan. Please review it again. Can I see the?
Yeah.
Note that there is no consolidation in peripheral space and no area space pneumonia, and all of the structures are vessels, and there's no mnemonic consolidation in the CT scan, and it's exactly normal. But when we are in the pandemic of COVID, all of the patients are
undergoing CT scan
yes,
and something,
yes.
So
and
in your opinion, you do not see this necessary for every patient with COVID-19 to undergo CT scan and data?
Exactly. We have a big problem in next year, and it's the radiation effects on these children and these neonates, and it's unbelievable. You believe that every CT scan in a neonate equal 150 chest X-ray radiation, and it's I cannot believe that.
It is a very important point that you
yes,
have made.
Yes, very important. And then in the next years, you can see the effect of this act on these patients, overdiagnosis with CT scan and chest X-ray in COVID-19.
Thank you very much for sharing your very good point of views. And next, I would like to ask here Dr. Naemi for point of view of this question. What should we do for a mother in progress that has COVID-19? And is there any vertical transmission in your experience? And if I may ask, can a mother with COVID-19 go for the lactation, go to breastfeeding of his child? Is it possible?
Hi, hello everybody. Thank you for inviting me to this panel. Can you hear me?
Yes, loud and clear.
Thank you. First of all, I want to tell that, COVID-19, in my opinion, is a very new phenomenon. So what I'm saying today probably might change too much in the next year, in next future. So this is what I know from nowadays, from little limited data and few studies. At present, it is uncertain whether there is a risk of vertical mother-to-baby transmission. Maternal viremia rates appear to be low, about 1% in one study, and it's transient, suggesting that placental seeding and vertical transmission are unlikely. And today, COVID-19 has not been detected in any cord blood or amniotic fluid. And few placental have been studies, actually, because there are not many studies on the placenta, but almost all had no evidence of infection. So one exception was a case report in Switzerland that in which COVID-19 in placenta of one miscarriage in second trimester pregnant woman was positive for COVID-19, but all amniotic fluid, cord blood, and maternal blood and vaginal sample was negative. Recently, two studies have assessed the possibility of vertical transmission of COVID-19 in 7 pregnant women affected COVID-19, and they measured the neonates' IgG and IgM level. They concluded that COVID-19 could be transmitted in utero based on the presence of IgM antibody in blood of 3 neonates out of 7. And however, all 3, the nasopharyngeal respiratory sample was negative. But after that, they show that a rapid decline in the infant IgG level and IgM level strongly suggests that IgG in neonates antibody were derived transplacentally, because we know IgM doesn't cross the placenta, but IgG crosses the placenta. So maybe it's because of mother infection, not because of the infant's infection. Totally. So what's the route of delivery? In our opinion, in American College of Gynecology, Royal College of Gynecology, FIGO, and many other guidelines, they recommended not to do C-section just because of COVID-19 infection. And C-section is performed for a standard obstetrical indication, not for just COVID-19 positive patient. And they say if vertical transmission is confirmed someday, this would not be an indication for C-section delivery, since it would be increased maternal risk and would be unlikely to improve a newborn outcome. And about the breastfeeding, also it's unknown whether the virus can be transmitted through breast milk, because available data are limited and to very small case series. Consulting with parents is necessary and it's inevitable. They have to choose whether they want to go for formula or they want to go for breastfeeding. By the way, all samples of breast milk from 26 infected women were negative for COVID-19. So we do not have any COVID-19 positive in breast milk. There is general consensus that breastfeeding should be encouraged overall in all the mothers because of its benefit to mothers and child. In the setting of COVID-19 infection, the infant may receive passive antibodies from mother, so it wouldn't be bad. But we have there is currently insufficient evidence regarding the safety of breastfeeding in this setting. If the mother is severely or critically ill, separation appears to be the best option. With attempt to express breast milk in order to maintain milk production, not to feeding the baby. If the patient is asymptomatic or mildly symptomatic, I think breastfeeding can be continued. And if mother and baby are separated, the infant is fed expressed breast milk by another healthy caregiver until the mother had recovered and have been proven uninfected. If you have any question,
Thank
I
you
would be
very
happy
much.
to answer.
It was very new knowledge for me, and I really enjoyed your presentation. And I
Thank
would
you.
like to thank you for joining us in this session.
Thank you
Next,
very
I
much.
would like you're most welcome. I would like to ask my dear colleague, Dr. Mirnia, about any special considerations in your opinion for the treatment of the COVID-19 patients in the neonatal period? And also, is there any place for hydroxychloroquine in neonates? Have you any experience with that?
Welcome to everybody. Thank you for your invitement. About hydroxychloroquine, there is no evidence still about it. And about the management of the babies with COVID, still there is no consensus. Just in a sporadic papers I have seen, they use the remdesivir, but the main consensus on the care of the baby with COVID is using CPAP and to support the ventilation of the baby. And as Professor Mohammadpour in the previous section said to us, it's the best way to support the babies with continuous positive airway pressure, or we have to say CPAP is the best way, but we have to give PEEP to the babies. About the medicines, what now we want to implement in the babies, still there is no consensus, and there is no really one strict medicine I can say to you that we are implementing now. We are using from the normal, usual antibiotics what previously we were using for these babies. I saw in your PowerPoints that they use azithromycin. Azithromycin anti-inflammatory. Because of that, they use that medicine, not as a treatment of the COVID. As a whole, if you want to talk, no, there is no special treatments in the neonates still, until my knowledge helps me.
To panic about the neonates with COVID, and we should just stay with our common and also used medications for the neonates, yes?
In my experience, as we had a baby what was born from a mother with COVID, these babies usually will come with unstable thermoregulations. So now use our own knowledge, I think we can try to overcome. But we have many reports from other parts of the cities of Iran that we have distress of distress. So if you want to overcome with these babies, we have to still use our previous guidelines for using CPAP and intubating the babies, or even if we need, we have to use surfactant too. If in case our baby is going toward the respiratory distress syndrome, we have to use surfactant too. So we have to use our previous guidelines for overcoming these babies, for treating these babies.
And finally, I would go to Dr. Abdul Salehi, my dear friend. And finally, I would like to ask him about the treatment of the patients with COVID-19, and ask him if he can tell us about the treatment strategy for these patients in detail, and what are the latest on that? We do not have your voice, Dr. Abdul Salehi. Just talk. Yes, your voice is on.
Good evening. However, up to now, there is no confirmed medication for COVID-19, but many drugs have been suggested and are under clinical trial worldwide. 80% of the affected children do not have any presentation, and as there is no specific treatment for COVID-19, the best management is following of the preventive measures. One important challenge in pediatric COVID-19 is when to start the treatment. We prescribe the drugs when the child is ill with pulmonary involvement. According to our experience and worldwide researchers, the most effective medications are azithromycin plus hydroxychloroquine for the moderate presentations, such as refractory fever, mild dyspnea, chest X-ray infiltration. And for those who are admitted, are give azithromycin plus hydroxychloroquine, and we may add antivirals such as Kaletra or remdesivir according to the clinical judgments and having the medication. Giving more information about the above mentioned drugs, I'm going to introduce some of them. One drug, hydroxychloroquine, it has antiviral properties against COVID-19. This medication works by interfering with the chemical environmental of human cell mechanism. Hydroxychloroquine treatment is significantly associated with viral load reduction in COVID-19 patients, and its effect is reinforced by azithromycins. The other drugs, remdesivir, which is an antiviral effective against Ebola, inhibits viral replication and reduces the mortality and hospital stay. Azithromycin, which is a macrolide antibiotic, has excellent tissue penetrations, anti-inflammatory and antiviral activity have also been reported. Most of the times, we prefer to prescribe azithromycin plus hydroxychloroquine together. Next, favipiravir or Avigan, it has been used for treatment of influenza in the China and Japanese. It inhibits RNA polymerase the virus. Some reports showed better survival, reduced hospital stay, but more studies are going to confirm its effects. And the last is drug Kaletra, which is the combination of lopinavir and ritonavir. And it is a famous HIV medication. At the beginning of the pandemic, Kaletra showed some good effects, but the other research questions its position. As other drug, it is under clinical trial to confirm the effect. It is reported to reduce ICU stay and improve survival. Some of the patients may be transferred to intensive care units, and if cytokine storm syndrome, IARDS, develops, we may consider to add it tocilizumab, which is interleukin-6 receptor antagonist, or anakinra, which is an interleukin-1 blocker, or corticosteroids. As I mentioned at the beginning, there is no confirmed specific treatment for COVID-19, and caring of the patient is mostly conservative. And the ongoing clinical trials will show the better treatment in the future and may solve the controversies. Thank you very much.
Thank you very much. Thank you very much, dear Dr. Abdesalehi, for sharing your valuable knowledge. This was our first session on COVID-19 and the pediatric patients. You are more than welcome to share your point of views with us. And I would like to thank again all of our participants and also our colleagues in the webinar. So we will see you in 2 weeks with new topics, and see you soon. Have a nice day. Bye-bye.